All right, good afternoon, everyone. My name is Farah Slaczka, and I'm going to be presenting with Mateusz Slaczka and Roshan Uruthirakumar. And our patient case today is internal anal sphincter achalasia, a rare cause of chronic constipation. So just briefly introducing myself, I'm a fourth-year medical student. This is a patient I saw during my third year with Dr. Bozeman, who is a pediatric surgeon. And Roshan and Matt can introduce themselves real quick.
My name is Mateusz Slaczka. I'm an MD3. I've been participating in helping do the research with Farah and Roshan on internal anal sphincter achalasia. Like Farah said, that she rotated with Dr. Bozeman. Came across this interesting case. You can go ahead, Roshan.
Yeah, my name is Roche. I'm a third-year med student. I'm actually interested in going into pediatrics myself. I actually rotated with Dr. Bozeman right after Farah did, and I was able to follow up with the mother of our patient and see how they're doing as well. So I'm really excited to be presenting it here with Matt and Farah.
Alrighty, so we're going to go ahead and get started. All right, so briefly on this patient, she was a 20-year-old female. She has had a long history of refractory constipation ever since childhood. However, she was never really fully worked up until 2020, and she was sent to the Children's National Colorectal Center. And there they did further imaging like contrast enemas. They also did colonic and anorectal manometry. And then they recommended that a biopsy be done to make a final diagnosis of what is causing her chronic constipation. So after the biopsy was done, they confirmed the presence of ganglionic cells, and that was a key in ruling out Hirschsprung's disease, which was on her differential list. And basically that left her with the diagnosis of internal anal sphincter achalasia, or IASA. So these are some images that were taken of this patient's colon during the contrast enema. So the images show the large colon and the sigmoid colon. So what the doctors were looking for was if they saw any transition zones, if they saw any obstructive lesions or any kind of strictures, basically trying to find anything that could be causing this patient's symptoms. And they also wanted to see if the colon was able to evacuate the contrast appropriately, which it was. So the negative findings of like no strictures, no lesions, no anything like that kind of left them with the diagnosis of internal anal sphincter achalasia. So a little bit about what this condition is. Normally, the internal anal sphincter is supposed to respond to rectal distension. And the response is through this reflex called the rectosphincteric inhibitory reflex. So distension of the rectum is supposed to trigger release of nitric oxide. And nitric oxide is a relaxant, so it's supposed to help the sphincter to relax and open, therefore helping, the person to defecate. But in IASA, there could be any number of, conditions that cause this. So it could be altered innervations. There could be the absence of nitrogen nerves. There could be defective neuromuscular junctions or an abnormal distribution of interstitial cells of Codgel. So any of these causes can, result in the sphincter not relaxing in response to that distension, therefore leading to the symptoms of chronic constipation, bloating, abdominal distension, all the things that this patient was experiencing.
Some of the symptoms that you'll see presented for internal anal sphincter achalasia typically present later in childhood and to adolescence. These patients typically had normal meconium passing at birth, which makes it difficult to diagnose IASA early in life. Symptoms include refractory constipation despite treatment with laxatives, stool softeners, and dietary changes. This can lead to abdominal bloating, pain, and general discomfort for them as well. Some differential diagnosis for pediatric chronic constipation. You have functional constipation, Hirschsprung's disease, anatomical obstruction, idiopathic constipation, spinal muscular atrophy, tethered cord, and then the internal anal sphincter achalasia that we have. Typical workup would be pediatric constipation is usually dealt with conservatively. This includes dietary changes such as increasing fluids, fibers, giving them stool softeners and laxatives. If these do not work, you may use an enema could be used. For patients with persistent symptoms, further workup is warranted, such as imaging and or biopsies.
So, in terms of diagnosing internal anal sphincter achalasia, it's a little bit tricky because it's one of those diagnoses where you have to rule out a bunch of other differentials first before you arrive to it. Upon initial exam, some of the earlier diagnostic imaging you would do is a contrast enema. But to make a definitive diagnosis, you need to do an anorectal manometry, and rectal suction biopsy is confirmatory. So with an anorectal manometry, you can see the image on the right. It essentially measures the pressure within the rectum, and it would be able to tell us that there's high pressures, and so that's what's causing the constipation. You would also see that in Hirschsprung's, and to differentiate with Hirschsprung's, you'd have to get that rectal suction biopsy to confirm. On rectal suction biopsy, you'd be able to see the presence of ganglionic cells. And as we know in Hirschsprung, there is an absence of ganglionic cells. So getting that rectal suction biopsy is key to confirm your diagnosis. Now, in terms of the treatments, there are two main kind of treatment regimens that you can go about doing. The first would be a Botox injection. These are performed as a 4-quadrant injection of about 25 units of Botox into each of the locations. You can see an example on the right there. That totals out to about 100 units of Botox. And basically what Botox does is it's a botulinum toxin that would block the release of acetylcholine, and blocking that release would therefore cause relaxation of the sphincter there. And at that point, you'd be able to pass the stool. Then we also have posterior internal anal sphincter myectomy. And what you would do with this procedure is you would basically go in and divide that internal anal sphincter muscle. It's a surgical procedure, and this would allow it to weaken and relax the muscles there, and therefore allow for passage of stool. And yeah, go into the next slide. So what are the pros and cons with each method? With Botox injections, which is what we saw this patient doing, the biggest limitation with that is the period of relief is only about 4 to 6 months. So compliance becomes an issue because you'd have to have the patient go back pretty much every 4 to 6 months to get these injections. However, the relief that they do experience with it is they do see a significant improvement, especially in the first few months. As the time period elapses, they do notice a little bit more and more constipation. But that